request Dr. Dinesh Talwar, sir, to talk on role of anti-VEGF in diabetic retinopathy.
Good afternoon, ladies and gentlemen. At the outset, I must thank Dr. Ajay Arora for inviting me to be part of this session, which I believe is a very important topic for all of us. Before I start, this is my disclaimer and the financial disclosure. We all know today anti-VEGF agents are something we're using right, left, and center. And they've almost become a panacea for all retinal disorders. So for a microangiopathy like retinopathy, this should actually be just what the doctor ordered. But isn't that too simplistic? It is, because diabetic retinopathy is not one particular disease. It is a continuum. And that continuum spans the entire gamut from preclinical retinopathy with no changes visible on the fundus to advanced end-stage diabetic eye disease. And in between you have NPDR, maculopathy, and proliferative diabetic retinopathy. So if you look at it, the treatment points for diabetic retinopathy are there. You have to see at each level. No retinopathy or early NPDR, the main treatment revolves around medical treatment. So please don't under stress on that. I think that's what Ajay was talking about. But the important thing to stress is that you can actually get a huge amount of improvement in your patients merely by stressing on medical control. The next comes the role for active ocular management, which occurs in diabetic maculopathy, in proliferative diabetic retinopathy, and sequelae of proliferative diabetic retinopathy like vitreous hemorrhage. So what are the issues of management in diabetic maculopathy? The first thing which I want to talk about is the fact that people talk about lasers now being obsolete. And then the second thing is about the anti-VEGF agents, which to use when and how. And finally, whether there's a role for steroids as an anti-VEGF agent, as an intravitreal agent. Now, this myth about the fact that lasers decreases the visual outcome actually stems from the fact that in the DRCR net study and in the RESTORE study, they found that the patients who had a deferred laser had slightly better improvement in visual outcomes as compared to those who had prompt laser along with an anti-VEGF agent. What people don't realize is that if you do the subgroup analysis of these cases, there were two groups. One group in which focal lesions were there, and they obviously must have had a focal laser, and the other group which had diffuse diabetic macular edema, and where probably a grid would have been done. It is the grid patients, is the patients with diffuse diabetic macular edema in whom the vision dropped following laser. It was not those who got a focal macular laser. So focal macular laser does not adversely affect the outcomes, whereas a grid probably does. So this is very important to keep in mind. Now you say, why is it referent? Because we are only talking in terms of center involving diabetic macular edema. But keep in mind, when you talk of center involving diabetic macular edema, you could have macular edema which is away from the center but which goes right into the center. And the points of leak, the points of origin of the fluid in these patients could arise far away from the macular center. And all you need to do is laser for that macular edema to be taken care of. Unfortunately, nobody stresses upon this fact that even center involving diabetic macular edema can very often be amenable to treatment with laser. In fact, if you see the data, both in this RESTORE study and in the DRCR net protocol I, some 50% of patients had focal lesions which were amenable to laser. So not doing the laser in these patients would skew your treatment towards more and more injections. Now, when you have a patient with DME, your approach to management starts with BCVA. And the problem is everyone thinks BCVA is distant vision. No, it's distant and near vision. Remember, this is a macular pathology. Near vision can be N12 and the distant vision may still be 6/9. This patient still needs treatment. So the important thing is both distant and near vision evaluation. Along with that, you do the OCT, you give the anti-VEGF treatments to decrease the severity of the macular edema, but before you do consider doing a focal macular laser, it would be good if you do a fluorescein angiography. And then subsequent treatment can continue PRN in these patients. This is just to show a patient who had a combination of some leaks within 500 micron of the foveal center and others far away, given an intravitreal agent to first decrease the amount of edema, then done focal macular laser, and then subsequently you can continue with the anti-VEGF treatment. But before you do any such focal macular laser, make sure that your patient is controlled as far as lipids are concerned. So no hyperlipidemia should be there. Now, which anti-VEGF should you use and when? This answer is very well answered by this question is very well answered by the protocol T. In patients whose vision is greater than equal to 618, ranibizumab and aflibercept are both equally effective. Now this is important to note because there are economic constraints and those get managed by knowing about this information. For patients with visual acuity less than 618, aflibercept monotherapy or maybe even an initial aflibercept followed by ranibizumab for maintenance may give you the same optimal results. And if there are economic constraints, please continue the patient on ranibizumab. Why not bevacizumab? Well, just to show you, in patients with good visual acuity, who have baseline visual acuity, the decrease in the macular thickness with bevacizumab was half of what it was with ranibizumab or aflibercept. So if I have to give a choice, I would give the choice of ranibizumab and aflibercept and not of bevacizumab. On the other hand, the poorer the baseline vision of the patient, the better the chance he has with aflibercept, if he can afford it. The other important thing to note is that there is no emergency for treatment. Even a delay of 2-3 months does not change the overall outcomes over 2 to 3 years, and so don't push your patients as if there's some kind of a tearing hurry for treatment. Get the patients to control their diabetes, get them to control their lipid profile, so that the patient does a comprehensive management of his eyes and not just a piecemeal treatment. Now, how do you treat the actual patient on the ground? If his distant visual acuity is better than 612 and better than N8, conservative treatment is the way to go. I would only give topical NSAID drops. I would not start anti-VEGFs because we know once you start, he'll need something like 8 to 9 injections in an year, and with only minimum benefit, as we know from the protocol T. But would no injections make them deteriorate? No. This has been confirmed by the protocol V that these patients would not deteriorate over a period of 2 years in majority of cases. So the safest approach would be continuous monitoring till early signs of deterioration occur, and then you initiate the anti-VEGF treatment. Patients who have a decrease in distant vision or a decrease in near vision both require initiation of treatment with anti-VEGF agents, which continues PRN from initiation. It is not a loading dose of 5 injections. It is PRN from the initiation and continued till the patient gets a vision of better than 612 and a normalization of his foveal contour. And then you can stop his further treatment. If this endpoint is not reached, you can continue the monthly treatment till you reach it. And if you get no further improvement, you can stop, continue on follow-ups, or you can give a trial of steroids to these patients. Remember, 25% of patients, even with ranibizumab, do not need any injections after the first 3 injections. This is based on the RESTORE trial. And these patients, whom you can call as elite responders, actually need just 3 to 4 injections in the whole year. The other important thing is, at the same time, there are 20% patients who will not respond through 2 years of treatment. So if you have a patient who is not responding to 2 consecutive monthly injections, by not responding I mean no change in visual acuity, absolutely no change in OCT, these patients should probably get a chance with treatment with steroids. The last group of patients in macular edema are those who are non-resolving. Before you say non-resolving, rule out vitreomacular traction, and then you can give them a trial of Ozurdex for a sustained effect, followed by anti-VEGF agents for maintenance and prevention of recurrence. 4-weekly OCT is still needed, and you can see this was one of those patients not responding to any monthly treatments till he got one Ozurdex, and suddenly the response came, and this will usually end up with a rebound 3 to 4 months later. That's why the monthly follow-ups are necessary. When you come to proliferative diabetic retinopathy, you have 3 things in your armamentarium: lasers, anti-VEGF agents, and steroids. You need anti-VEGF agents or steroids in combination with your lasers to decrease the macular edema and get better visual outcomes. The protocol has showed us that you could do monotherapy with anti-VEGF treatment. But what was the main advantage? Lesser effect on the peripheral field. But if you actually go and check how much is the effect of peripheral fields, a study in UK showed they actually could all pass their driving test even after a PRP. And furthermore, I believe that in today's era, if we decrease the distance from the arcades, leave some area next to the arcades, maybe another 1 disc diameter, your 30-degree field would not be affected. Remember, in patients without DME, you need something like 7 injections with monotherapy in the first year, 10 over 2 years. But in patients who have macular edema with PDR, you need up to 14 injections in 2 years. And in these patients, if you add a PRP, these patients actually needed half the injections, 9 injections. Maybe there is a role for PRP to bring down the incidence of macular edema in patients also, which we need to keep in mind. So how do I manage my patients with proliferative diabetic retinopathy with maculopathy? If it's a raised neovascularization, I would complete the laser first and use anti-VEGF treatment later. If it's a flat neovascularization, I would give an anti-VEGF and quickly complete my laser, because these patients are very amenable to this combination. And if NVE is persistent after adequate laser, you need anti-VEGF agents. Probably the optimal treatment is a combination of PRP with anti-VEGF agents. Now, as regards monotherapy, what is this? Is that a good way? I think it's like catching a tiger by the tail. We know if these patients don't come for follow-up, they have a very high incidence of losing their eyes. So, monotherapy, only if you've counseled the patient about the need for 14 or more injections in 2 years, with the possibility of more laser, need for regular follow-up, risk of traction detachment surgery requiring surgery, and the fact that the number of injections can keep on increasing more in diabetic macular edema. So this is possibly more suitable for PDR without maculopathy rather than those with maculopathy. In patients with vitreous hemorrhage, we don't use anti-VEGF agents as a primary therapy, but use it preceding a surgical intervention 2 to 4 days before, and to bring down the incidence of a bleed during the surgery.
Dinesh,
Ladies and gentlemen, I conclude by saying judicious use of anti-VEGF agents as part of a multi-pronged attack can definitely help to preserve and improve visual functions in patients with diabetic retinopathy, possibly even indefinitely, and even with optimal cost. So please make sure your patients get that and keep them seeing. Thank you very much.